We're going to talk about the opioid concerns in older patients. And I am Al Fisher. I'm the chief of the Division of Geriatrics, Gerontology, and Palliative Medicine in the Department of Internal Medicine. And with me is my co-presenter.
Hi, I'm Alona Balasanova. I'm an addiction psychiatrist in the Department of Psychiatry.
So kind of our initial disclosures. So this is part of our GWEP program, which is the Geriatrics Workforce Enhancement Program, which is funded by HRSA. And so this is funded by HRSA funding, but these content represents our opinions and not that of the federal government. More importantly is that if you have, for access to these materials as well as others, you can go to our website for the Nebraska GWEP, which is shown at the bottom of the slide. Definitely feel free to reach out to any of us, including Mary Jo Spurgeon, who is our program director, to get access to them. So the goal of today is to talk about opioids in older individuals. And so I'm sure that we all have a lot of experience with taking care of older patients or general internal medicine patients in general that take opioids. And just to give you a sense to how big this issue is, about 9% of clinic patients by older or clinic visits by older patients involve a prescription opioid medication, and consequently about 9% of folks over the age of 65 do take a chronic opioid. And importantly, as people get older, they become more susceptible to the side effects and the adverse effects of chronic opioid use. And as a result, we're now starting to see more people presenting either with a sequela of opioid use disorders or with an opioid use disorder as the primary issue. And as we've all heard, that the evidence for the use of chronic opioids outside of malignant cancer pain is fairly weak, and in older individuals, this is indeed the case as well. So there have been clinical trials doing things where they've compared a fixed dose of an opioid versus dose escalation. And with that, they've found no difference in the perceived pain level reported by the patient. So if the thought is that if we could titrate the opioids to the right dose, and then the person would have relief of their pain, this study sure argues that we're not able to do that easily. Similarly, other studies have been conducted using opioids to try to address a lot of patient-centered outcomes like physical activity, function, sleep, mood, quality of life, and those have also been largely negative, really arguing that the benefits of chronic opioids are at best modest. Additionally, while we always think about a lot of the consequences of opioid use in younger individuals like addiction and dependency and diversion, while those exist in older individuals, there's additional consequences of chronic opioid use that these individuals show. So for example, long-term use of opioids is associated with cognitive decline, and short-term use of it can lead to the precipitation of delirium. Additionally, we always worry about opioids and falls. Interestingly, the data doesn't really support an increased rate of falling in older individuals that use opioids, but instead it's actually an increased risk of fracture, suggesting that when they do fall, those falls are more injurious than in non-users. And then there's actually some really interesting data showing that there are a number of consequences that we really wouldn't have thought of. So some things like increased risk of car accidents, maybe not too surprising, but there's actually an increased risk of either cardiovascular events or pneumonia in people who are using chronic opioids. So the challenge then becomes, well, if we're not going to utilize opioids as our primary means of pain control, how can we help patients that are coming in with pain complaints? And this slide just shows a lot of the data that I'm sure a lot of us have run into in other settings, such as other approaches to low back pain. So things like a pain control clinic where they can do steroid injections can be an approach. Similarly, you can use SNRIs, TCAs as an alternative strategy for back pain. For neuropathic pain, approaches like SNRIs or gabapentin or pregabalin are potential options. In osteoarthritis, steroid injections, Tylenol, topical NSAIDs, especially now that Voltaren has just gone over the counter, and so patients can actually purchase this at the pharmacy directly and aren't dependent upon a prescription or a prescription plan to get access to it. And then finally, for fibromyalgia, approaches use it like using antidepressants, gabapentin, as well as behavioral non-pharmacologic approaches such as exercise or options.
All right, so screening for opioid use disorder. So we know that chronic opioid use can lead to an opioid use disorder, right? Doesn't mean it has to, but it certainly has in our country. And so it's important that for just as much for older adults as for younger adults, we make sure to screen for opioid use disorders and other substance use disorders. There's been some really interesting research just recently that came out about bias within providers and not screening older adults because of a bias that, you know, older adults don't get addictions and this population is immune, which unfortunately is not true. And what it results in is actually missing a very treatable condition. Because opioid use disorder, out of all the substance use disorders, is actually the most highly treatable. So how do we screen? There's a number of options available. There's the WHO, the World Health Organization, developed internationally a tool called ASSIST, which is the Alcohol, Smoking, and Substance Involvement Screening Test. And so it is kind of an internationally based one, so it's not necessarily tailored to populations here. However, it's still equally valid. It's an 8-item tool. And it's used to detect and manage substance use and related problems in primary care and general medical care settings. It even has a patient feedback report card that then is shared with the patient. So really helping to enhance collaborative care with the patient. NIDA, the National Institute on Drug Abuse, which incidentally, we don't actually use the term drug abuse anymore. We use misuse. As that is one of the stigmatizing terms that's been found to actually hinder care. However, NIDA being a government organization, you know, would require an act of Congress to change it. So the name sticks and we still have NIDA. That being said, it's a really great organization. They have a plethora of resources on their website, how to assess for opioid use disorders in the pain management setting, as much as in other settings as well. You know, a lot of these screening tools focus on underlying risk factors for substance use disorders. So prior history of substance misuse, whether or not that was an opioid, you know, perhaps alcohol or tobacco. Family history, you know, over 50% of one's risk for developing a substance use disorder is actually genetically based. So if somebody, you know, their parents, their grandparents really struggled with substances, they are going to be inherently at higher risk. So it's important that we make sure to screen those individuals. And then also patients who simply report using opioids for non-medical purposes. Sometimes patients will have the insight to acknowledge that and to say that outright. So it's important that we ask them directly, you know, do you ever use these medications for reasons other than for which they are prescribed? And that one question can actually catch quite a bit of folks if answered honestly. You know, we also have our prescription drug monitoring program, which in Nebraska is the best in the country, without a doubt, because we can actually see all the medications that a patient is receiving, not just the controlled substances. But this really helps us see if a patient's receiving medications from different providers. Maybe they're getting a benzodiazepine from one provider, an opioid from another. You know, that combination can be particularly troublesome for older adults. So that's just another tool that we have in our toolbox in helping to screen patients and have conversations with them about their opioid use. So how to reduce patient harm from opioids. So say we've screened them and we've identified that perhaps there's a problem, or maybe, you know, there's something, the beginnings of what is going to grow to be a problem, and we really want to nip it in the bud. So, you know, for those that are naive, for those that really haven't had a lot of exposure to opioids or not on chronic opioids, starting slow and for short periods of time is really the best way to go. So, you know, a post-operative procedure or something very acute, really giving a short duration, 7 days or less. We know that 75% of opioids that are misused are obtained from a friend or family member. So we don't want to be giving out a lot of opioids that may not be necessary, not only for our patients, but for their family members, right? And for just our community at large. We also have a great resource in our primary care mental health integrated clinics. The pharmacists, the PCMH pharmacists, have a deprescribing program. So you can place a referral in Epic for PCMH pharmacy for tapering off of opioids and benzodiazepines. They actually do it all, and they really work directly with the patient to tailor a plan that is going to be customized for their dosage, for how much they're taking it, how long they've been on it. And so it's a really great adjunct tool that we have is our pharmacy colleagues. So offering treatment for opioid use disorder when indicated, we do the screening, we identify there's a problem. You can initiate treatment right then and there if you are a DATA 2000 waiver prescriber of buprenorphine or Suboxone. Alternatively, we're very happy to be able to provide the service here at the addiction psychiatry clinic that we have, which I direct. And so you just place a referral in Epic to addiction services, outpatient referral to addiction services. Our staff reaches out to the patient. You don't have to do anything else. We schedule time to talk to the patient, identify what their needs are, get them in the clinic. Right now we're doing things by telehealth, but the speed with which we're doing them is the same as if they were in person. So, we get right on it. And then if they are here in the hospital, say the patient's hospitalized for some reason, we also have an addiction psychiatry consult service, which I also co-direct. And we actually start Suboxone and other management strategies right here in the hospital when someone's hospitalized. So that's just another option if your patient happens to be hospitalized. We're happy to consult in the inpatient setting. So referral for buprenorphine treatment, patients are unwilling to consider opioid tapering with you. Buprenorphine is a really great choice. Alternatively, of course, there's always the methadone clinic for more higher risk patients that perhaps buprenorphine wouldn't be appropriate for. So that's something that, we'd be happy to assess and refer if necessary. So one of the pocket cards, which I think Al usually you talk about, right? The pocket card.
Yes, we have a couple of tools that we've created that are available. I think we've sent some of these to your clinic. If there are any that we've overlooked, definitely feel free to reach out and we're happy to get them to you. One is that there was a request for how do I do the oral morphine milligram equivalents, or MME, that a lot of times insurance now is focusing on how much opioids are patients taking. And so this is an easy way of doing those conversions. And so you can see the calculation down at the bottom. And there what you want to do is take your dose size, the number of doses per day, and then the factor from the table above to then be able to do the MME. And so, for example, if you're taking tramadol 50 milligrams twice a day, that's 50 milligrams times 2 doses times 0.1, and ends up being 10 milligrams equivalent of oral morphine every day. We've also developed a provider brochure that has the same content as our talk in it, and this is, I think we've sent some of these already, but we certainly are happy to send more. And then importantly, for having discussions with older patients, we've created patient guides that are in either English or Spanish, depending on the patient you're working with, that has the same content and really goes at the same talk, but from a patient perspective and at a level that's more appropriate for patients than for healthcare providers. And so in summary, what we talked about today is opioids are frequently prescribed in older patients, and chronic use is not uncommon. And importantly, when you're seeing an older patient who takes chronic opioids, remembering not just kind of the usual things you're thinking about with younger patients, like the risk of developing an opioid use disorder, but also thinking about things like cognitive decline, auto accidents, and some of the health consequences that could develop from chronic use. And often things like the auto accidents or vulnerability to losing cognition or driving abilities really can be motivators for patients for wanting to reduce or stop the use of opioids. And finally, for folks who are using chronic opioid therapy, there are a number of routes you can go forward with. So screening for an opioid use disorder, offering deprescribing, particularly through the pharmacist into PCMH, or referring folks on for treatments such as buprenorphine. So at this point, we'll wrap up and take any questions.
When you guys, if we refer on for like buprenorphine, do you guys, how do we put the referral in? Is this referral to psychiatry?
Yeah, so so there's a special referral order. Thank you for asking. So it's outpatient referral to addiction services. So if in Epic you just put in addiction services, really honestly, I think just actually if you just put in addiction, I think it should pop up. And then you just place that consult order and sign it in Epic, and then it, we get it directly, and then our staff reaches out to the patient. So you don't have to do anything in addition to that. Then of course, if the patient, isn't interested, that becomes a different story if they're not willing to really talk to us. But presumably, the providers that do place that consult would have had a conversation with their patients about the referral and that, they'd like for them to see us.
That's always the challenge, isn't it?
It is. It is.
Yeah.
Thank you, guys.
Yeah, thank you very much.
Okay,
Thank you.
Appreciate it.
awesome. Thank you for your time today.
Thank you.
You have a good day.
Bye.
You too. Bye.
Thank you, everyone.
All right.
Great. Nice.